Bertahan. Am I audible?
Yes, doctor.
So good evening, my dear friends. Sorry for the delay. So being working days, this is something which happens most of the time. It is like we have to wind up the practice and start with the sessions. So I'm not wasting much of your time. So thank you all for the participation. So we'll start. Dr. Juna, is it fine? Let me start the thing.
Yes, doctor.
Yeah, fine. So that's about me. I am a private practitioner. I am practicing in Cochin for the last 19 to 20 years. And endodontics and restorative dentistry is something which I always focus on. So that is my operatory at Kochi. We have a practice with the operating microscope. Let me pause for a while. There is some technical glitches here. Some delay, the thing is stuck. Let me figure it out. Yeah, I am sorry. There was some technical glitch. My system was it was hung, so I had to restart the system. Anyway, so I hope you all would have seen this movie. Yes, the Apocalypto. So basically, the endodontics and restorative dentistry today. Sadly, I have to say that we are still in the Stone Ages. So, with the advancements in dentistry, most of the time we speak about implants, digital dentistry, or something which is in vogue today, that is the clear aligners. So, here in restorative dentistry and endodontics too, we have a lot of developments happening. And that is what an introduction into that world is what I am going to do today. That is, we would be seeing the recent developments in the field of restorative dentistry and endodontics, wherein the biggest advantage is that those teeth which we were most of the time extracting can very well be saved with a very really good prognosis now. So that is the biggest advantage we have in the modern day endodontics, which when we combine it with the modern concepts of restorative dentistry also. So here at present we are I mean, ours is the only program which focuses on restorative dentistry and its beautiful symbiosis with the modern trends in restorative dentistry. So, before beginning with the real crux of the things, let me tell you something. This program is an introduction into the modern world of restorative dentistry and endodontics. So here I would be showing you the possibilities of this side of dentistry. So let's start with a case discussion because, see, myself being a clinician, it's much more, for me, it's much more comfortable. And I always feel that when I communicate things, communicating through a case would be always really effective. So, what you see over there is a semi indirect I mean, semi-indirect composite overlay. So you can see a root canal treated tooth, which was crowned and it landed up in a failure. So we had to go ahead with a strategy so as to save this tooth. So the root canal treatment was completed. You would see the rebond basketing. The core buildup was completed. And then we make an impression. We'll send it to the lab for a full contour wax up. And you can see here, if you follow my cursor, you can see here an index of the wax up is made. We'll remove the wax from the cast. We'll place composite into the index and get things together. Fine, and like your. And this is the resultant restoration. You will have a composite which is shaped according to what the wax was shaped into. And that would be bonded onto the tooth. Then finished and polished, occlusion, everything is equilibrated. Fine, that is how we go ahead with a restoration now. Gone are the days of root canal treatment, caps, all those things. And you can see the occlusion, and you would also notice that there is no line of demarcation, nothing. So here you have the X-rays also. We'll see another case wherein you can see a tooth with a polyp. So again, you would see how we transformed that into a beautiful restoration without a post and core, crown, all those things are not there. It's just a direct composite restoration after the root canal treatment. So this is what we are focusing on. This is the type of dentistry which I focus on. And this is what we teach also. So let me divide it. We had a polyp. So I'm just loosening the polyp with my rotary file inside. So I'll introduce a bit of sodium hypochlorite. And you can see the polyp is turning pale. The pulp tissues are dissolving. Now we'll remove the pulp tissue with a steel round ball. And again, sometimes we can use an ultrasonics also to refine the pulp chamber. You can see that happening. Now you can see an intact pericervical area. We'll go ahead with the build-up. I'll place the buccal and lingual walls, the sectional matrices for the proximals, the peri-endodontic restoration, root canal treatment was completed, a ribbon wallpapering in the pulp chamber, followed by the completed build-up. I'll show you another case. It's very beautiful to look at. And you can just message what would be the restoration done over here. So hit your message box, just comment on what are the measurement, what would have been the restoration done in this case. Let me see what it is. Okay, I cannot open the chat box now. So you can just unmute and tell me what would be the type of restoration which this tooth has undergone, and if so, which is the tooth which has been restored.
Sir, I think midline diastema is covered here.
Acha, it's a midline diastema closure. Any other option? I mean, any other guesses?
Sir, 1, 2.
Okay, fine. What was the preoperative situation here? So this was a 4.5-year follow-up of a fractured tooth. Let me show you the situation. So this was a situation. You can see the tooth was fractured. The patient had a fall. And the fracture line appears favorable from the facial view. It's an oblique fracture wherein palatally it is expanding to the mid-root. The flap was raised, the bone was trimmed, the deep margin was acquired. We went ahead with a modified rubber dam clamp for the isolation. Root canal treatment was completed and the fractured fragment was reattached. And you can see from the IUPA that the composite is gone to the mid-root. Fine. Now we can see that those things which we have read and we have learned about the prognosis of restorations, they don't hold true here. It's a 1 month follow-up. It's a 1.5 year follow-up. And that's a 4.5 year follow-up. Still, the tooth is retained in the mouth, and you can see the IUPs. In fact, you can see the bone level has been improved over the ages. So this is what endodontics combined with restorative dentistry is making possible today. Excuse me. I'll show you another case. This was, in fact, an eye-opener case, I would always say, in my career. It's like, you can see a root canal treatment was done. After a while, after a few months, the patient came in with pain. An IUP was exposed. It was evident that it's a case of vertical fracture. The tooth was extracted. It was stuck back, again reimplanted, followed up for 2 years. It took up very well. This was taken as an abutment and a bridge was given. The bridge is there for the last 12 years. So I'm convinced adhesive dentistry is going to work. So that's just an introduction. Now let me get on to the crux of things. So let's start with the diagnosis. So endodontic diagnosis is often very simple. And basically, we would always say, before shaping the roots, we must shape clarity. That is what endodontic diagnosis is all about. And you all know it's not a rocket science. Most of the things are straightforward. The patient tells you, and I will not be discussing about what are the indications for a root canal treatment here, which I'm sure you all know very well. But again, there are some situations wherein things can become a bit dicey. So see this case here. So a root canal treatment was done. After a while, the patient came with a complaint that wherever you have done the root canal treatment, the tooth is paining. And when you clinically evaluated, you saw an abscess pointing. The first thing that we have to do whenever we see a sinus or a pointing abscess is to trace the sinus tract. So here you can see that the GP is tracing towards the adjacent tooth. So here you can convince the patient that the culprit is the adjacent tooth. At the same time, you have fabricated a proof that the tooth you have treated is not the culprit over here. So this is something which is very important for us, that is documentation. So in the modern day practice, documentation has a very important role. Fine, it's not just managing cases. We have to very well document things also. And I'll show you another situation, something which most of the time we may overlook. So here you can see the second molar. You have a periodontal breakdown there, or rather I would say that a localized periodontal breakdown. And most of the time, this case, the upper left one. You can see my cursor moving. So here, most of the time we would think that it's an endo-perio case and go ahead with doing an endo followed by a perio, etc., etc. So something which you have to always keep in your mind is always suspect a root fracture whenever you have a localized perio issue. An extensive bone loss, which is on an isolated tooth, is something which is always pointing towards a root fracture. Another situation is a disproportionately wide canal. All these things would hint about a root fracture. In such cases, we may have to go in with a CBCT. Fine. So let me show you a case. So you can see a periodontal breakdown. As earlier we said, just one slide before I was telling you, it can be a root fracture also. So we'll take a CBCT. We didn't see any fracture. So in such a case, we will think of doing a retreatment. And here you can see that the mesiobuccal mesiolingual is ledged. There's a huge lesion along the distal canal. And this patient was giving me a history of root canal treatment failing twice. The retreatment was started. You can see the ledges were bypassed. Mesiobuccal and the mesiolingual bypassed. Calcium hydroxide dressing was placed. And since the patient was giving me a history of root canal treatments failing twice, so I just kept the calcium hydroxide, covered the tooth with a permanent filling, and now we have to wait and watch whether the lesion is healing. So that is a follow-up after 2 months. You can see that the lesion is healing. So that is the immediate IOPA after the calcium hydroxide placement. And you can see the next one, wherein the healing has started. Now, we have made it sure that the body is responding, the tooth is responding. So we'll go ahead, complete the root canal treatment. That's a completed root canal treatment. Then you can see a 3 months post-operative, the entire lesion is healed. So something which you have to always keep in mind is when you have the correct diagnosis and the correct armamentarium, of course, with the right set of skills, treatment is always successful. So most of the time, another issue with dentists would be, we would be starting a treatment without a preoperative radiograph. So here you can see that the premolar is dividing into 3 roots, something which is very common. When we are going ahead with the slides, I show you many cases wherein we have 3-rooted premolars. Sometimes you can have 4 canals also. So such cases, pre-treatment radiographic evaluation is mandatory. Now I'll show you a radiograph. So on seeing the radiograph, I would urge you all to tell me what are the issues over here. Don't tell me that we have a deep silver amalgam restoration. We are not bothered with that. And don't tell me we have an MO on the 8. Might as well we will extract that also. So we are going to start with a root canal treatment on the second molar, and tell me what are the challenges you would be expecting in this case. Yep, let's have that fast.
Difficulty in
unmute?
isolation.
Pardon?
Difficulty in placing rubber dam.
Why?
Isolation.
Why?
So deep.
The clamp is going to be cervical there. There will not be any issue in placing a rubber dam.
Calcification.
Yes, of course. The pulp chamber is obliterated, so you will be having a tough time, and you are not able to trace the canals over here. So calcification is one issue. Then
Extra canal.
where?
Chance of extra canal.
Pardon?
A chance of extra canals, more canals.
Chance of extra canal. How can you say that from an IUP? No, what you said is correct. I'm just asking you, how did you come to that conclusion?
Maybe angulation, change of the angulation may show it.
Okay.
So there may be
angulation of the-
So you are
It's
just
like
making a guess over here, that is, there can be an extra canal.
The
It's
pulp
like
chamber is obliterated.
Pardon?
there's an overlap of roots.
Pulp chamber?
Yeah,
Sir,
you said
yes.
it's obliterated. So now see this IOP.
Deep
Curvature of canal.
Can you see two
Separates,
outlines on the mesobuccal root?
Yes.
Two root outlines. So that is what we have to look forward in starting such cases. That is, you have to look for the pulp chamber, look for the canals, and look for extra roots or canals. So here you can see the view from the microscope. You can see the MB1 and MB2, and here it was two separate roots. So in 90% of the cases, the MB1 and MB2 fuse at the apex. So if you don't get the MB2 also, your case is going to be successful. But there are 10% of the cases where they are separate. So you cannot take a chance in such cases. Fine. This is one such wherein it's separate, MB1 and MB2. You can see the separate canals here. And then we go ahead with the obturation. You can see that the third molar is removed. So whenever you are in doubt, on the presence of a second mesobuccal canal, imagine you are doubtful as to whether there is a second mesobuccal canal. So one big mistake we do is we sit and search for the canals. We take a bird, we start gauging the floor of the pulp chamber. You may land up in a perforation also when you're doing that. So whenever you doubt, stop there. Take a CBCT, see the slices, and see here you can see that there are two mesobuccals. Accordingly, you have to search for that. Now, one big thing which we have to consider here is gone are the days of conventional access opening. The first thing that we have to do when we are going to start with the root canal treatment would be to convert the tooth into an anti-fragile design, something which we were never speaking in our conventional dentistry. In our dental schools, these things were never taught. That is, before starting a root canal treatment, we just saw the IUPA, went ahead with the access opening, no more. We would convert this tooth into an anti-fragile design. All the unsupported enamel, all the weak cusp, etc. would be removed from this tooth. Let's see how it is going. Mike, no, leave it, leave it. Mike, So you can see all the unsupported cusp is removed from the tooth. And that's the tooth now. So we don't have any fragile, unsupported enamel. We don't have any weak cusp. All the weakness of the cusp is gone now. Now, this is the stage we would be going ahead with the axis opening. I'll show you another video. This is on an extracted tooth. So I'm removing the silver amalgam restoration. So now you can see that I've removed all the unsupported walls from the tooth. And then I'm going ahead with the axis opening. And you can see the breach now. One sec. So I've removed all the unsupported walls. And you can see a small breach on the roof of the pulp chamber. So this is your landmark. Don't look forward for the drop. Fine. You may mess up the full thing when you, check for the drop. A drop is something you will get only on an intact extracted tooth. Fine. A tooth which was caries and later which has gone in for a root canal treatment, most of the time the pulp chamber would be obliterated. You will never get a drop. So slowly you would remove the dentin from the areas of the roof, and slowly we will start seeing a breach into the pulp chamber. So that is the landmark which you have to look for. Now inspect visually. So the floor of the pulp chamber is going to be dark in color. That's called the law of color change. So here you can see a glistening yellow. What does that mean? You have a stone there and you can see the stone moving. So when you suspect a stone, the first thing you would be doing is take a file, check for the patency of the canals. So here the canals are patent, which means the stone, the pulp stone is not adherent to the floor of the pulp chamber. It's loose over there. It's easy to remove that. And if at all the canals are not patent, that means you have a tough time. So you can see the pulp stone moving. Now we would remove that with ultrasonics. She will break that with the ultrasonics. Yes. It's a bit more of the stone palatally, which is hidden under some remnants of the roof of the pulp chamber. So there's a bit more of the stone remaining. I'm removing that with the DG16 Explorer.
Hi, sir.
Hi.
In this case, can we just enlarge the opening bit more?
Yeah, that is the biggest mistake we do. We simply take our bird and remove a lot of tooth. So let's talk about all these things once I finish it.
Okay, sir.
So, so note down your questions. We would address everything.
Okay, sir.
So you can see with the ultrasonic, all the stone, everything was removed. And so see, something which we have to remember is, see, we don't have to open the tooth too much. We'll always keep things as minimal as possible. Now we'll go into an access opening on a mandibular molar. So you can see all the unsupported enamel is removed. We don't have V cusps now. All the V cusp would be trimmed down. So you can see the breach. Now we would de-roof and look at the direction of my bird. I am taking it out. It's not going in, it's wiping out motions. It's always outward motions so that you don't create any perforations. So it's the expulsive cavity design, and you can clearly see all the canals now. So something which we have to understand is, to improve our visibility, we have to resort to magnification. Removing a lot of tooth material, tooth structure for better visibility is not something which we are looking at. See, the canals are so clear and the tooth is not having any fragile components. So this is what I was telling you. See, we don't require a crown after root canal treatment, but the thing is, we have to convert the tooth into an anti-fragile design. Then it makes sense going ahead without a crown. So let's see a clinical case. So we have a single rooted tooth, a carious premolar. As a clinical picture. So we'll always start after rubber dam isolation and the same protocols. We remove all the fragile elements from the tooth. So I've gone ahead with the deep margin acquisition with a plastic wedge. You can see the deep margin is very well acquired. So these are the differences now we have. Fine. And you can see the breach on the roof of the pulp chamber. And once you get the brief, your movement is always outward. And in this case, I'm using reciprocation. That's a reciprocating file going to the apex. Or you would say just straightening the coronal third. Now we'll go ahead with the working length determination as a deep margin acquisition. Elevating the deep margin. Now the proximal buildup, the sectional matrix band. That's done. Now I'll go ahead with the determination of the working length. We always go with apex locators. That's how we connect the apex locator. One electrode onto the soft tissues and the other one connected to the file. So there is a learning curve with the apex locators, a fluctuating reading here, which means the canal is bigger and I may have to go with a bigger diameter file, which is snugly fitting at the apex. And now we can see things have changed. I am getting a very stable reading. So now to the working length with reciprocation. That's a sonic activation of the irrigants. It's a sonic activator which is going down. And you can see the effervescence of hypochlorite. That's a master cone. Now dry the canals. And coating a bit of sealer on the apical third of the master cone. Taking it down. And you would now see the warm vertical compaction. I'm taking my heat source. I will just keep 5 millimeter of the GP at the apex. The remaining GP would be heated and removed. Now it would be compacted down. You can see that. Then we would backfill with thermoplasticized gutta percha. That's a backfill going inside. You can see the GP extruding. That's right. I'll show you another case of polyp. That's a preoperative X-ray. That's the coronal flaring. Hypochlorite irrigation. You can see how quickly the canal is becoming clear and clean. Or the other way, clean and clear. Then we'll go ahead with determination of the working length with the apex locator, of course. We don't prefer IUPAs for the working length. Working length is always determined by the apex locator. So before starting with the irrigation, there were some leaky areas on the rubber dam, which is sealed with the liquid dam. You can see I'm using two clamps over there. One, the anchor clamp, which is a W8A. Then on the tooth which I'm working, I'm using a B4 brinker also. Again, reciprocation here, not rotary. So hypochlorite irrigation, suction. The distal canal is a very huge canal. See, in the measles, I'm progressing to next bigger files. We started with the 24% in the beginning, and we shifted to. So the distal is a huge canal. My hand file number 40 is the first file which is binding at the apex. It's so huge. So the working length is determined. The 40 was the first file which is going to the apex in this case. Now that's the hand file which is connected to the K400 handpiece. That's a handpiece which is used, which can be used with the hand files. That's the handpiece which can accommodate the files. So I prefer to do the cleaning and shaping in that way. Then irrigation everywhere, activation with sonics. That's the 30 gauge side vented needle going in. We don't use the normal syringes. The clean, beautiful canals, which would be obturated with bioceramic and GP. So I'm not using a warm vertical here. That's a bioceramic sealer, which is injected. There's the obturation going on. We'll fast forward a bit. Removing the excess GP, vertically packing it with a plugger. So we would inject a bit of sealer. Place a single cone. Then pack a bit of Teflon into the pulp chamber. No cotton inside the pulp chamber. It's all sterile Teflon. That's a light cured temporary material. Cure it. It's very easy to remove that also as obturation. We'll see another case. In this case, I'll show you how to check for the MB2. And here you would see a very special trick, which is very effective in finding the MB2. That is something which always works. So that was a composite restored tooth, which later went in for a root canal treatment. I'm removing all the fragile elements and the old composite restorations. Now the pre-endo buildup is done with a wedge and a liquid dam. And with the ultrasonics, I am refining the isthmus over the mesiobuccal canal. And we look forward to uncover the ovoid shape of the mesiobuccal canal. I'm refining the pulp chamber with ultrasonics. There's the coronal flaring. So we have a very different technique of coronal flaring. So I'm not a big fan of the coronal shapers. So I'm using a normal file. Now you can see that I am exposing the isthmus of the mesiobuccal root. Can you see an oblong shaped orifice there? A round orifice which is continuous with the isthmus. Now take your DG16 and probe the isthmus. Wherever you get a catch, that's your MB2. You can see the MB2 there. That's one of the most practical techniques of finding the MB2. You can see the small MB2. Distopalatally placed. I'll just negotiate with the glide path file. Done. Okay. That's a 10K file going in. There's a pre-op X-ray, another case, wherein we make an impression in the beginning. We'll make a full contour wax up. We'll go ahead, remove the soft tissue which was covering as a deep margin acquisition, which will be followed by the root canal treatment. All the fragile elements are removed. You can see the clean, clear canals. You can see the debris floating. There's a cleaning and shaping in progress. Irrigant activation. obturation with bioceramics and single cone. Also, this case I've done backfill also. A combination of bioceramics with the backfill. And you can see the palatal canal is dividing into two at the apex. Now this would be followed by the composite buildup. I'm converting the class 2 into class 1. All the 4 walls are made as a ribbon placement. Now finally, we have the old wax up. That's a preoperative wax up was done. Now an index would be made. And according to the wax up, we have done an injection molded direct composite restoration. Direct composite only. That's a post-op. Now we'll see some very interesting cases. So here a curved root with files fractured in mesiobuccal and mesiolingual. So that's a case wherein you can see the files were bypassed. So what do you mean by bypass? We'll take a file, we'll make it pass by the side of the fractured instrument, and we will negotiate the canal to the apex. So here you can see that the apical third is very thin. Without losing the anatomy of the canal, we have bypassed the files as a master cone. The obturation. I'll show you a mesially angulated IOP also. So the fractured files are bypassed and obturated. And you can see the fractured old files are entombed within the obturation. So I'll show you a very special type of irrigation, which is called the continuous irrigation and suction. You can see 2 tips over there. One is a suction, the other is the irrigating device. This is called the CRCC. So heated hypochlorite would be continuously circulating in the canal system. Video is not playing. So this is another very interesting case. So you can see it's a case of dense invaginatus, tooth within the tooth. I'm sorry. It's like I don't have the full case. Anyway, let me see whether I have the full case. So, which later it's like if at all I go to my the other presentation to take out that full case, then it's like some issues with my system, it's getting hung. So we'll start with another case. Here you can see, sometimes we'll end up in big trouble. This was a case referred to me by a friend of mine for a root canal treatment. So I really wanted to impress that guy. So I went ahead with a very conservative axis opening and landed up in fracturing a file. So most of the time what people do is only the glorious cases are shared. So see, I'm showing you my own failures. So this is how it landed up. I fractured a file inside. And now you can fracture a file if you can retrieve it. The file was retrieved and then obturated. You can see again the single canal dividing into 2 at the apex. And this is another beautiful case. This is the only case reported so far wherein a fractured instrument was retrieved from the MB3. It's not from the MB1, not from the MB2, it's from the MB3. So here you can see the preoperative IOP. The file was fractured in the MB3. So I opened up. You can see the MB1, MB2, and MB3. The file was in the MB3. First, I tried bypassing it. Then finally, the file was retrieved and then went ahead and obturated. So this is another case wherein a file was fractured and it was pushed beyond the apex. And even in such cases, we can give an attempt. I made an attempt to retrieve it. And what I could say is at that time, in that case, I was lucky enough to retrieve it. So it might not happen in every cases. I will show you other cases also wherein I had to open up the flap and remove it by episectomy. So here it was like the patient was lucky, I was lucky to get the file out through the canal itself. Another case wherein similar thing, it was pushed beyond the apex and was retrieved. This was another case wherein you can see a fractured instrument. This was retrieved by the BTR, broken instrument retrieval pen. So you would grab it like this and fish it out. The file is, it's a tube and loop technique. You can see the file was retrieved and obturated. Here this was a very interesting case. The file had gone periapically. And you can see I had to, open it up surgically. Episectomy was done and the file along with, the file was removed. And you can see this radiograph wherein healing has started. So all these things need to be addressed. And this was another case wherein coronally there was a crack also. The crack was dissected. You can see the composite going into the mid-root level. It's another technique in the management of badly mutilated teeth. Most of the time we have cracks indented. The cracks need to be identified and removed. So here the crack was identified and you can see that how we get the hint of it. You can see the periodontal breakdown on the distal aspect. Now you can see that is healing because the crack was removed. This was the case we were talking about. See the dense invaginatus case. So that was a maxillary central incisor. You can see the 4 canals with the open apex. That was managed and you can see the final follow-up wherein the lesion is healing. And later, the buildup was completed with composite. That's a composite buildup. So things can be managed in this way also. This was a case wherein the tooth was discolored. It was a complication which developed after orthodontics. The tooth was totally sclerosed. And this is one case which I would remember throughout my life. I literally had to go to 21 millimeter with ultrasonics to open up the sclerosed canal. So I had to go to 20 millimeter with the ultrasonic, holding on to your nerves literally, because there is every chance you can land up in a perforation. To this depth, we had to go with the ultrasonics, started getting a catch. Later, the canal was negotiated and obturated. You can see you have multiple portals of exit. You have lateral fills, all those things. And then a walking bleach was done to bleach the teeth and obturate. You can see the pre and the post. Another case, this was a dentist also. She was a dentist. So she had a root canal treatment done, which failed. A post-and-core was done. Everything failed. And then there is a gingival polyp, which is growing into the root. Then never we had any restorative space. We never had a restorative space also. So that is the anti-fragile conversion. Retreatment was done. A full composite restoration was done. No post, no crowns, nothing. This is called a delayed direct restoration. And you can see the emergence profile. This was a very difficult case. Somehow I could manage it. Routine cases wherein posts land up in a problem. Here you can see that was a perforation of a post space, which was the post was removed, the perforation was sealed, and the tooth was saved. Another case of bleaching, walking bleach, you can see. See, even this degree of discoloration can be managed just with bleaching. That's another fabulous case. You can see this was done 10 years back. So here it was open apex and the mesial root has a huge lesion. So after the treatment, not only that the lesion healed, there was continued root development. So it was a apexification which later got transformed into revascularization. So you can see open apices, a huge lesion along the mesial root, and you can see the follow-up of the case after 6 years. And you would see that there is continued root development which has happened and total healing of the lesion. So all these things do happen. That's another case, a case of pulpotomy. So it's not very, it's like you don't have to do a proper root canal treatment always in the adolescents. So here it is like you can see the open apex with a decay, coronal decay. The coronal pulp was removed. And you can see the follow-up wherein the root formation has happened. There are still some other cases wherein you have to surgically intervene. That was a huge cyst which was enucleated. So sometimes we have to manage a case surgically too. Then again, this was a very tough instrument bypassing. There was a curvature along the distal root and the apical third had a fractured instrument. Later, the instrument was bypassed. The fractured instrument was bypassed without losing the anatomy of the canal. You can see an S curve over there. So it was nicely bypassed, obturated, and then we did the restoration with this is called the stress reduced direct composite only. That's the restoration. Again, a case of deep margin acquisition. A customized copper foil was used over here for deep margin acquisition. You can see the customized copper foil. Endo was completed, and then the post-endodontic restoration with an overlay. You can see how nicely the overlay blends with the tooth. Okay, this is a case which is which was done in Emacs. And sometimes we have really tricky cases. Here we had a really curved canal. And that was a retreatment also. You can see how we manage the curvatures. We have a very special technique for curvature management, wherein it is like most of the time it is very easy to manage the curvature when we have the right technique. So here I was lucky enough, I had a curved root here and a very peculiar anatomy of the first molar. That too was a retreatment there. Again, a 3-rooted mandibular premolar. You can see the 3 canals. The observation. So this is what I had to share with you all. So take this as an introduction into the contemporary aspects of endodontics, as well as its symbiosis with the biomimetic restorations. So this is what we would be focusing in our workshops, in our 3-day endodontic workshops. So if at all you are interested in knowing more about such restorations, you can always join our workshops and learn more. My great mentors, Dr. David Aleman and Dr. Devi. So if you're interested in joining our courses, here are the numbers. You can take a screenshot, you can contact us and join the courses. And if you're interested in seeing more of these cases, you can see them at my Instagram page. Here is the QR code. You can come and you can scan it and log into my Instagram page, and you can see the fabulous cases over there. So with this, I wind up with my presentation. We'll have a small Q&A session. So I saw a lot of chats since the recording was on. I was not able to access them. Now we'll go ahead. You can unmute your mics, and you can straight away, you can ask me if at all you need any clarification.
Sir, you had used handpiece, right, for hand filing. Can you name what did you use?
That was a K400 handpiece.
Okay. And the classes which we're talking about, do you conduct those classes in Bangalore, or we have to come to Cochin? And how's the case, sir?
It's in Kerala.
Okay, so thank you.
Okay, thank you.
Sir, can you please tell me in a situation where Articaine is not effective as a local anesthetic, then how to manage that case?
Articaine is always effective.
Yesterday, sir, I had a case where nerve block was not effective. Articaine,
Nerve block may not work in a single tooth anesthesia, right? You may have to
yes,
give an intraligamentary.
okay,
Fine. So you may have to give an intraligamentary or an intrapulpal when the nerve block is, I mean, nerve block cannot be 100% effective though, due to cross innervations.
okay.
Fine.
So can we do retrieval without having special retrieval kits?
Retrieval is always possible. This is one thing which I would always say, never try a retrieval without a microscope. It's like sometimes retrieval may happen with loops also, but the thing is like we may end up removing a lot of dentin, and when a lot of dentin is removed, eventually the tooth has to fail, right? So whenever attempting on retrieval, you have to have the right armamentarium. You have to have tools for the retrieval. You have to have the ultrasonics. You have to have many other, accessories are there for that, plus an operating microscope.
Okay, thank you, sir.
Thank you.
Sir, in one case, you told that there is no use of post and core, no need anything, and only the composite is built up on that dentist
Yeah,
case.
post and core and crowns are all, to me, I would say those are the bygone eras of dentistry. We would always, try to avoid all those things.
Sir, then that composite is enough to bear all the occlusal forces?
A crown is never enough. A crown always, see how many cases you have seen wherein post and core and crown has failed.
Yes, sir. But sir,
Fine.
I
So
think
that itself proves it. That itself, so that's a old concept, and it's not good to stick on to that old concept even now. Fine, we have better techniques.
Sir, then on composite buildup, we can also use crowns, which
You don't
can
have to
like
use
bite.
crowns at all.
Okay. Then only composite is stand bear all the occlusal forces and stress.
See, that is what I said. You would have seen the ribbon fibers, right?
Yes, I know, sir. I know, sir, ribbon fibers.
Yeah, Fine. So you need, I mean, see, first thing is you have to fine tune the occlusion, you have to rebuild the composites, you will have to rebuild the dentin with composites which are similar modulus of elasticity as that of the dentin. You have to use gold standard adhesives. You have to then go ahead with enamel replacement, everything. First, I mean, most importantly, you have to equilibrate the occlusion and verticalize the forces. If at all you can do all these things, your composites always last more than the crowns.
Sir, but there is no ferrule. There is no ferrule where
See,
you
that is
use
what,
that.
see, I mean, see, it's like you're talking about something which is historic dentistry. Ferrule is never important in adhesive dentistry.
Okay, then we have to remove some soft tissue around the crown, around the CJ level.
That is what I said. No, a ferrule is not at all important in adhesive dentistry. What you're talking is the old traditional conventional dentistry where you would need ferrule and all those things. When you think of post and core, crowns, etc., ferrules are important. But I'm not talking about those things. Those are, to me, just things of historical interest only. We have moved on from that.
So what is the procedure name that what was the name of that procedure?
Pardon me, I didn't get you, ma'am.
So what procedure that you told something delayed? The procedure you used for that?
Delayed direct.
Yeah, delayed direct.
सर अभी एक यस्टरडे का एक केस था, मैंने सर एंडो किया था और फिर उसके ऊपर सर लिथियम डाइसिलिकेट का इमेक्स का ओवरले दिया था, लेकिन सर 1 साल के बाद वो ओवरले फ्रैक्चर हो गया एक साइड से। तो सर इसके अंदर सर क्या रीजन हो सकता है? अभी मैंने सर शुरू किया
बहुत
है।
सारे रीजंस होंगे। इट इज लाइक वन थिंग इज लाइक आपका ओक्लूजन इक्विलिब्रेट करना चाहिए था, आपको फोर्सेस वर्टिकलाइज करना चाहिए था, और
सर ऑक्लूजन चेक किया था वहां पे।
another thing is it is like when you're doing the build up you would have, I mean before starting the root canal you should have converted the tooth into an anti-fragile design, lot many things. Fine.
Doctor, it is not a mandate. Is it mandatory that for every root canal case we have to go for a post-endo restoration? I mean, an indirect restoration?
I didn't get you, man.
Soon after the root canal treatment, is it mandatory that a post-endo, I mean a biomimetic restoration or any restoration, I mean, an end,
so you mean to say that
has
after the root canal treatment, you just leave it with a temporary filling?
Not temporary filling, a composite.
You have to, I mean, it's like you will do, right?
Yeah, after the composite, should it go, is it mandatory that it should go for any indirect or direct restoration? I mean, should it be a crown or a biomimetic?
If your composite is very well executed, then you don't require anything more than that. In many cases, it depends again.
That is what I asked.
The cases also.
Okay, so how will we judge those cases? Is it according to the number of walls or, I mean, the condition of the tooth?
So whenever we expect a too huge bulk of composite, we always try to keep it, I mean, we always try to take it to an indirect restoration. The reason being, how much ever careful we are, there is always a problem of polymerization.
Chance of fracture.
Polymerization shrinkage. So bulky composites, there will be high amount of polymerization shrinkage stresses coming. Fine.
So other than polymerization shrinkage, doctor, won't there be a fracture?
No, that is what, ma'am, I was telling you. The first thing is we have to fine tune the occlusion. We have to make sure that the forces are verticalized. There is no lateral stresses coming on the tooth.
Okay, okay.
So see, let me express this in a different way. See, a root canal treatment with a crown is very easy.
Yes.
Without a crown, it's going to be too difficult. There are too many things which you have to do. It's very, very, very specific. It is very, very, very intensively, I would say, focus oriented.
Okay.
You may take 3 or 4 times more time what you were taking for a root canal treatment and a crown. Things are going to be much more difficult.
Oh, okay. Okay, sir. That is all. Okay. Thank you.
How to verticalize the force, sir? Occlusal force.
Okay, you are, I mean, it's like, if at all we have to speak about the occlusion, one full day is not enough. It's a vast topic on how to verticalize the forces, how to equilibrate the occlusion, all those things. And that is the saddest plight. We don't learn all those things in our 5-year bachelor, when graduation, when we are doing. That's the saddest part. So working on the occlusion is something which is very intense, and I will not be able to discuss the full things in an online program like this. Fine.
Okay, sir.
Thank you.
Can you explain retrieve of files from the canal?
Pardon?
Can you explain me for retrieve of broken files from the canal?
Yeah. Most important thing when we have to retrieve a file from the canal is whether it's visible or not. Fine. If your file is visible, it is always easy to take it out. So mainly what we do is we need ultrasonics, then we need loops which can grab on to the fractured instrument, lock it, and then retrieve it.
Okay.
Fine. So that is why I was telling you, you need an operating microscope for that, ultrasonics, and there are some other retrieval tools like the loops and things like that, which you need. So when you have all these things, retrieval is possible.
सर
Thank you.
दो इमेक्स वाले केस के अंदर सर मैं जो टूट गया है वो पोर्शन को फिर सर कंपोजिट से बिल्ड कर सकता हूँ कि नहीं कर सकता हूँ?
कर सकता है ना, क्यों नहीं कर सकता है, मैंने दिखाया ना.
So some methods are saying that a conservative opening should be done.
Sir, your voice is breaking.
So some mentors are saying that we should do conservative access opening so that without crown we can do RCT. Is this okay or any?
And that is what I was also saying, right? You never need to do, I mean, crown after root canal treatment is an age-old concept. You never need a crown after root canal treatment. Or rather, I would put it in this way. If you put a crown after root canal treatment, your tooth would fail faster. But don't think that now this is going to be a straightforward technique. Here you have to convert the tooth into an anti-fragile design first. You have to, I mean, to be very specific during the root canal treatment, you have to reduce the stresses, you have to do the dentin buildup, you have to then do the enamel buildup, and then you have to verticalize the forces. If at all you can manage it in this way, then you don't require crowns.
हेलो नमस्ते सर.
नमस्ते.
सर एक क्वेरी मेरी ये थी, एक तो सर इतने सारे फाइल्स जो रोटरी फाइल्स है वो मार्केट में है, मतलब कई बार ये कंफ्यूजन हो जाता है कि कौन सी फाइल्स है जो बेटर रहेगी हमारे लिए.
You are the best person. See, first
thank
thing
you.
we have to understand. First, we have to understand that the most important component is you yourself.
Yes.
It's our skill.
Sir,
it's our skill which is going to be something which really matters.
जी. सर एक चीज मुझे जो प्रॉब्लम आ रही है वो ये आ रही है कि सर जब मैं मास्टर कोन एक्सरे लेती हूँ तो सब कुछ फाइन लगता है, कोई प्रॉब्लम नहीं आती. बट सर जैसे ही मैं बायोसेरामिक सिलर सिंगल कोन ऑब्जर्वेशन के लिए यूज करती हूँ, उस टाइम पर सर मुझे ये प्रॉब्लम आती है कि मतलब मेरा ना जो कोन है सर वो 1 mm शॉर्ट हो जाता है एपेक्स से. तो सर उस सिचुएशन में मुझे मतलब मैंने 3D इरिगेशन करके भी देख लिया कि ऐसा भी नहीं है कि मैं मतलब लिक्विड DDT भी यूज करके सब चीजें मतलब कर रही हूँ मैं, बट ये जो मुझे ये प्रॉब्लम आ रही है ये सॉल्व होने में नहीं आ रही है. ये मुझे कई बार ठीक लगता है बट मोस्ट ऑफ द टाइम यही होता है कि पहले मास्टर कोन एक्सरे लिया सब ठीक है.
What happens in such cases is it is like see, I mean most of the bioceramic sealers, it is like they start to set when you're going down.
Okay. So
if
क्या
you
solution है?
take one, then I mean there is always a chance that you will not be taking it to the apex. Another thing is, if at all your cone has crumbled up, when you were using it for your tuck back checking or things like that. That is also possible.
तो समझ नहीं आया, दोबारा समझाओ.
See, imagine आप आपका टक बैक ट्राई कर रहा था.
हाँ जी.
So there is a chance that the apical end of your cone got a bit damaged.
अच्छा, मतलब टक बैक के कारण से प्रॉब्लम आ रहा है, तो सर टक बैक तो आना चाहिए ना सर.
टक बैक आना चाहिए. It is like continuously imagine if you are pushing it out,
ओके
pushing and pulling it out.
ओके
हाँ,
ओके
तो
ओके ओके.
कौन डिफॉर्म हो जाएगा ना.
ठीक है. और सर मतलब जो हमें सर पेपर पॉइंट हम ड्राई करते हैं सर बायोसेरेमिक सीलर के टाइम पे, सर उसमें कितना सेकंड्स का सर हमें मतलब उसको रखना चाहिए कैनाल में?
I didn't get you. Once again.
सर जब हम पेपर पॉइंट ड्राई करते हैं सर कैनाल, तो उसका कोई पर्टिकुलर टाइम होता है ना सर, इतना टाइम के लिए आप पेपर पॉइंट ड्राई करो, ओवर ड्राई नहीं करना है, तो कितना सेकंड्स के लिए हमें जाना चाहिए?
There is nothing called over drying. You should not be, after 2 or 3 paper points, you should not be seeing any wetness ideally.
Yes.
अगर फिर से wetness हो रहा है तो it is like your canal is weeping.
नहीं सर, वो मैं समझ कैनाल ड्राई बाहर वो पेपर पॉइंट ड्राई आ जा रहा है बाहर. आई मीन टू से, क्या ऐसा कोई क्राइटेरिया है कि इतना सेकंड ही पेपर पॉइंट को कैनाल में रखना है, इससे ज्यादा नहीं रखना? ठीक है सर. एक क्वेरी और थी सर मेरा.
Only thing is that after, I mean, removing all the moisture, you may wait for a while. You may wait for 10-15 seconds. Place one more cone and see. That's it.
ठीक है. तो सर फिर मेरा ये प्रॉब्लम सॉल्व करने के लिए मुझे आप लास्ट सर क्या मतलब एक डायरेक्ट बता दीजिए कि ये कर लो, इससे सेट होने का चांस है.
Which one? कौन सी प्रॉब्लम?
सर वही शॉर्ट होने वाली.
Short होने वाले, I mean, it is like something which I have never faced, and I don't get why it is, I mean, why you are having that problem. If your master cone is problem and correct, then I don't see any chance for your master. I mean, have you taken, I mean, in your master cone X-ray, if things are fine, and I don't understand why it is going 1 mm short.
सर तभी तो मेरे मुझे
में भी तो हो सकता है.
हाँ, तो she did all those things ना.
सब कुछ कर लिया है.
Master cone also, right? Master cone IUP also, right? Then while obturating, how can it be 1 mm short?
सर देखिए, मैं एक बार बताती हूँ आपको. पहले मैंने मास्टर कोन एक्सरे लिया, ठीक है. उसके बाद में हम जैसे EDTA लिक्विड से हम उसको इरिगेट करते हैं, उसको सोनिक एक्टिवेशन से एक्टिवेट करते हैं. फिर हम जाते हैं अपने
One second, please, one sec. See, it is like after trying, I mean, after master cone, you are starting with your irrigant activation.
तो वो मैं ये चेक करने के लिए ना कि सब कुछ ठीक है कि नहीं है, कैनाल शॉर्ट तो नहीं रह रही है.
I'll tell you one thing. After your master cone X-ray, go ahead, dry the canals, obturate.
Okay, मतलब बीच में कुछ
you are instrumenting, again if you are instrumenting, you would again create debris.
Yes.
Which can pack up apically.
ठीक है.
So that can be one reason. Otherwise, I don't find any reason. So, thing is, if at all you have taken the master cone X-ray, keep that to the end. Then dry the canals, obturate. Don't instrument first.
जो सर सॉरी सर, एक सर जो हाइपो हम यूज कर रहे हैं, हाइपो तो सर सिर्फ डेब्रिस, आई मीन टू से सिर्फ जो अपना क्या बोलते हैं इसको, सॉरी, मतलब सिर्फ सॉफ्ट टिश्यूज को तो सर वो डिसॉल्व करता है, वो हार्ड टिश्यूज को तो इम्पैक्ट डालता ही नहीं ना सर.
I'll tell you something. See, imagine you went ahead with a file. If at all you are using a file.
No sir, I'm not using file.
Acha, okay, you didn't put an instrument, just your hypochlorite only, right?
Yes.
It cannot be possible, no. If your master cone is correct, then it is like only one instance is your sealer has started to set.
तो सर सीलर मुझे मतलब सीलर चेंज करके ट्राई करूं एक बार.
ट्राई करते हैं.
कौन सा सीलर सर आप एडवाइस करते हैं जिसकी फ्लोएबिलिटी अच्छी हो?
My pick is always the Metabiomed. Cerasil from Metabiomed.
Okay, Cerasil.
That's the only sealer I mean, I use whenever I'm using bioceramic.
ओके सर, मैं इस चीज के लिए. और सर एक और क्वेरी थी, सॉरी सर, जैसे आप कह रहे थे डायरेक्टली रबर डैम यूज करो, तो सर कई बार ऐसा होता है ना कि जैसे फूड लॉजमेंट हुआ होता है जिंजावर एरिया में, जहाँ क्लास 2 होता है, और तो सर वो जब तक वो सॉफ्ट टिश्यूज को हटाया हमने, DME करा, DMA करा, उसके बाद में ही सर कई बार रबर डैम लग पाता है। जैसे आपके केस में मुझे अच्छा लगा वो जो टेफलॉन वाला आपने कल परसों बताया था, तो मैंने वो टेफलॉन से ट्राई करा तो हो पाया। बट सर वो
कैसे?
टेफलॉन को जैसे
टेफ्लॉन,
आपने
हाँ,
बताया
ओके,
था ना,
टेफ्लॉन, ओके।
यस यस, तो सर वो टेफलॉन लगाने के बाद में जब मैंने ट्राई किया कि टेफलॉन लगा हुआ है और मैं मैट्रिक सिस्टम लगा रही हूँ, तो सर मतलब सर वो मुझे उसमें थोड़ा सा प्रॉब्लम आया थोड़ा।
मतलब कैसे प्रॉब्लम आया, क्या क्या प्रॉब्लम्स आया?
जैसे जैसे जब मेरा बैंड ना सर वो जा नहीं रहता सर प्रॉपर सर्वाइकली ना, फिर वैसे मैं टेफलॉन को तो नीचे तक लेकर गया था प्रॉपर, ऐसा नहीं था कि उसको ऊपर छोड़ दिया था,
हाँ, ओके, फाइन, गॉट इट।
बट मुझे थोड़ा सा
So
हेल्प
that
आउट हुआ है
struggle is
डेफिनेटली।
the part and parcel of dentistry. Fine.
यस
So
यस यस।
something which we always require is a presence of mind. We have to devise a
हम्म
technique first.
हम्म
Fine. So imagine you have a tooth wherein there is a proximal decay. The proximal walls are rough.
हम्म।
Imagine you didn't notice that. Your
यस हो
dam is
सकता
going
है।
to tear off. The moment you put the dam, your dam is going to tear off.
हम्म।
And again, another instance I would give you, there is a bit of gingival excess which has been intruding into your pulp chamber.
यस।
There is no other option. You have to remove the soft tissue.
ये हाँ जी 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 सर,
Cauterize it, you remove it with burr, you remove it with what BP blade, you remove it with laser, whatever, you have to remove it. Only then the the dam has to go apically to the soft tissue.
बिल्कुल सही है सर।
Fine. So in that case, it is like you cannot put the dam first and then go ahead with the treatment. No, you have to do the deep margin acquisition by gingivectomy, and then we have to go ahead with the dam. In case you have a class 2 wherein the walls are sharp, you have to take your burr, round off the margins, remove all the sharpness, and then go ahead with the dam. Otherwise, your dam
यस
is
सर,
going to tear off.
बिल्कुल सही है सर, बिल्कुल सही
Fine,
है।
that is what we just go to analyze the situation, then go to plan it out. Fine. And
सर
it is not mandatory that every time you have to put the dam and then start. No, nothing. Fine.
सर आज एक केस आया मेरे पास में, उसमें सर पैलेटल वॉल बिल्कुल गई हुई है और
Sir,
4 to
how to
5
build
mm
a
डाउन, सॉरी।
composite?
One sec. Let one person complete and then I'll come.
तो सर जो
Yeah.
वॉल सर बिल्कुल सर बहुत ज्यादा डाउन जा करके, उस केस में ना मेरे पास में कोई क्लैंप लग पा रहा था, मतलब कोई सिचुएशन मेरे से मैनेज नहीं हो पा रही थी। ऐसे केसेस में
See,
सर मैं
that is
क्या
what
करना
I
चाहिए, थोड़ा
showed you
इजी
a
हो जाए।
case wherein the tooth was fractured off at the middle third,
यस
right?
यस सर, यस सर।
So literally I had to tinker the clamp. You have to bend the clamp, you have to customize the clamp.
ओके।
Fine. So, I mean, that is what I said. See, I mean, I showed you many cases wherein I was just going through the slides and people think that things are very easy. No, it's not like that. Things are extremely difficult when you come to managing certain cases, extremely difficult.
यस सर, यस सर, यस
And if you think they are difficult, it is always going to be difficult. See, sometimes you have to think about ways, you have to plan it out.
यस सर, यस सर, यस
And there are many cases wherein we open the flap, keep the flap opened, and then go ahead with the clamp or rubber dam isolation. And finally, after the root canal treatment, we remove the flap and we remove the clamp and then close the flap and put the suture.
तो सर मैं क्या कर ले रही हूँ, मैं थोड़ा सा ये बताइएगा इसमें थोड़ा सा करेक्शन हो सके तो। मतलब मैं क्या करती हूँ सर, पहले वो टेफलॉन लगा करके पूरा पैक करके कोशिश करा कि वहां पर कोई भी फ्लूइड ना आए। फिर मैं क्या करती हूँ सर, कॉम्पोजिट थोड़ा सा बिल्ड करने की कोशिश कर लेती हूँ उसको, देन मैं क्लैंप लगा पाती हूँ सर।
See, here it is like I would tell you one solution. It's like these are situations where we would learn by failures only. So there are, I mean, see, in my case, I would say that there are certain things which can work very good with me, but there are certain other things which never works with me. So first you have to understand your advantage, I mean, your plus points and your inadequacies. Accordingly, we have to plan out things. See, something which is working for you may not work out for you in a proper way. So it
बिल्कुल
depends
सही
from
बात है।
person to person.
थैंक यू वेरी मच सर,
Thank you.
थैंक्स अ
Thank you.
लॉट।
Yep.
ओके सर,
Yep. Who
ओके
was
बाय।
asking me? I mean, in between. I mean, you can go ahead.
Sir, how to bond the composite with the fracture Emax crown? And if we want to remove the
Oh yeah.
fracture
It's like you will not be able to do that as a definitive restoration. If at all your emax is fractured, the only possible way out is to grind out all the emax or remove it. If at all you have a hard tissue laser, you can use that to easily remove the emax. You have to remove the emax, grind it off, and then repeat the procedure. That's, you will not be able to completely bond a composite to an existing emax. It can be a provisional. After some time, it has to fail. Okay.
Okay, sir.
Thank you.
And
Sir,
sir, I will see that cases where the fracture is there already, the teeth is fracture. Then this happen with me when the
So
teeth
whenever you have
is
a fracture, I'll tell you, I would explain that. See, you have two situations, a crack and a fracture. A through and through crack is a fracture. So repairing a crack is possible, and there is something called as crack dissection for that. You may have to go to the bottom of the crack, remove that, and then go ahead with restoring it. If it is a through and through crack, if it has gone to a fracture, then your prognosis goes down.
okay, sir. Okay.
Fine.
Sir, in fracture, sir, we can remove that fracture line, and we use all that procedure for buildup of composite, like etching, bonding, and flowable. Then this
I
crack
showed you a
will.
case wherein we extracted, stuck it back, and reimplanted also. No, so it's like nothing like things cannot be managed and all. Things can be managed.
So what will be the protocol for this fracture management? If there is a small cracks are small in the.
That is what. See, that is what. See, these are all things which I need to show you. I need to make you do, and then I need to teach you. Fine. These things, the biggest problem with these things are these techniques are so specific, so much skill oriented that just speaking about that will never do any good.
Sir, one more question. Sir, if
So I would say that if at all you have to learn these things, you have to join a workshop. I will never say join my workshop. You join any workshop from a good mentor, learn the technique properly, and then start using on patients. Never, it's like hear these things from many places and never try it on your patient. You may land up in a big trouble.
Okay, sir. Sir, if bioceramic sealer is expired, then can we use
What
this?
is expired?
It's a bioceramic sealer.
Huh.
Can we use this for some time after expiry date?
If it is expired, then it is like throw it off and start with a new one. Why you have to use an expired and all?
But it looks like nice. All kinds of things.
Do you prefer working with an expired thing inside your mouth or your parents' mouth?
So actually, sir, I just want to know what
No,
what
never
should
do.
we do?
Never. Why we have to do such things? If it is expired, remove it. You should not be using it.
Okay, sir. Thank you.
Sir, when rebound basketing is required?
In all cases.
All cases.
In all post-endodontic cases, remote basketing is required.
Sir, how do you manage, what is your protocol in weeping canal?
See, I would tell you one thing. The moment you start with good irrigation, 99% of your, you would see that 99% of your weeping never exists. So why we have something called as weeping canals in our textbook is at those times, our irrigation protocols were not that developed. Now it is like, see, you have n number of techniques for very good, excellent irrigation, and rarely you find a weeping canal. If you have a weeping canal, keep calcium hydroxide, recall the patient after 14 days. Still, if it is weeping, still irrigate, keep the calcium hydroxide, recall the patient, repeat the same thing till you get a dry canal.
सर रिबॉन्ड फाइबर की जगह हम जीसी एवरेक्स फ्लो या डेंटिन यूज कर सकते हैं?
Nothing. There is no substitute.
Sir, can you please name some good composite?
See, I always tell this thing. See, all the materials which is coming from reputed manufacturers are all, I mean, they are all good. So the biggest thing we have to understand is the most important factor is our skill. When managed properly, all these composites work well. And whatever composite you are working, if at all your management is not proper, nothing is going to work also. So we always say like this, your composite is always like your mother-in-law. The smallest mistake you do, it's never tolerated.
आप कौन सा यूज करते हो सर
I
कंपनी
have
का नेम
everything. I use Tensply, I use GC, I use 3M, Curare, everything is there.
ओके सर थैंक्स
Hello, sir.
सर एक और
Tell me.
What is
Sir, I
your
have a question.
observation protocol for obturating open apex cases?
Provide an apical plug of MTA and then go ahead with obturating the case. With I would always prefer a thermoplasticized gutta percha for obturating the rest of the canal.
Okay, sir. Thank you.
Sir, in which conditions we should use this vertical compaction
Yeah,
or
I'm a big fan of
thermoplastic?
I am a big fan of vertical compaction. So when it's like if time permits, I would say every case I would be doing a warm vertical compaction. That is something.
Sir,
Yeah.
okay, sir, but the single cone obturation also good, na, sir, in everywhere.
Single cone with bioceramic sealer works. Otherwise, single cone obturation is never good.
Okay.
सर एक क्वेरी ये थी कि सर आप कह रहे हैं कैल्शियम हाइड्रोक्साइड का, तो जैसे मैंने आपका देखा आपने कैल्शियम हाइड्रोक्साइड पूरी कैनाल में इतना नीट एंड क्लीन पूरा फिल कर रखा था, मतलब जब मैं करती हूँ उतना नहीं होता, बट जितना भी होता है उससे भी सर रिजल्ट्स मिल जाते हैं, तो हमें क्या इतना पूरा
I am doing this for the past 20 years. No, if at all I'm not doing it in a good way, then it is like I have to stop doing this.
सर आई मीन टू से जो मेरी क्वेरी है वो ये है कि जैसे कैल्शियम हाइड्रोक्साइड जैसे हमने पूरा 3D क्लीनिंग करा, उसके बाद में लास्ट में हमने थोड़ा नीचे कैल्शियम हाइड्रोक्साइड डाला, उस वो फिर पेपर पॉइंट से उसको नीचे प्लेस करने की कोशिश कर ली, सर फिर भी वो अच्छा रिजल्ट दे जा रहा है, तो मुझे इतना पूरा फिल करना रीजन क्यों जरूरी है?
Not at all
ये पूछना चाह
required.
रही हूँ।
See, periapical delivery of calcium hydroxide is important.
Yes, 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 yes.
Till the working length, you have to make sure that calcium hydroxide has to go.
हाँ जी सर, हाँ जी।
And most of the time, something which always helps is individual specific immunology.
Yes sir, बिल्कुल सही है।
If that individual on whom we were working on, if that individual's immunology is really good, everything works.
सही बात है।
But you will not be able to generalize that for every case that we are doing. So what we do always, our attempt would be to do the best possible in all the cases.
सर आप कौन से
Sometimes we
टिप्स
may be
से
sick.
करते हैं?
Fine.
आप कौन से टिप्स यूज करते हैं सर? जैसे जो बायोसेरेमिक सिलर में जो टिप्स आती है वही आप इसके लिए यूज करते हैं कि उसमें सर डायरेक्ट थोड़ा थिक होती है ना सर उसकी, तो कैल्शियम हाइड्रोक्साइड के नीडल्स तो?
See, for me things are very simple. It is like if at all I'm using a calcium hydroxide, I mean if at all I need to use calcium hydroxide for my routine cases, I would use just normal calcium hydroxide which is mixed with saline or
Okay.
Fine. And if at all I have to use a calcium hydroxide for a longer time, I would use an oil-based calcium hydroxide like a Metapex. So whenever I'm using Metapex, I have the tip with me. Metapex gives the tip.
Yes sir, yes sir.
So whenever I'm working with powder liquid which is mixed, I would use my master cone, I would do BMP, I would select my master cone, I would place calcium hydroxide into the canals pump with my master cone.
ओके अंडरस्टूड सर, अंडरस्टूड। एक्चुअली मैं प्रीमिक्स यूज कर रही हूँ ना। ठीक है सर, ठीक है। ओके, थैंक यू वेरी मच सर।
थैंक यू
Sir.
Yep.
How will we understand the periapical scar and healing of a lesion? How can we differentiate
that is
from the
one big
IOPA?
issue we are having. It is like most of the time, it is the periapical lesion, whatever it be, it can be replaced with, without a bone formation. You can have even a cholesterol clefts left over there. But that doesn't mean that the case is going in for a failure. If at all the lesion is staying like that for years together, then it's like you may leave it. If you find it
problem.
increasing in its size, then it shows that your treatment is a failure.
Okay, sir. Then we have to check.
Fine.
We have to check the patient, review the patient, right?
Everything is dependent on follow-ups.
Yes, yes.
Fine.
Okay, sir. Thank you.
Thank you.
Good evening, sir.
Good evening.
Sir, in one of your slides, I have seen that you have used pre-endo restoration with liquid dam. Do you always advise pre-endo restorations with liquid dam, or is it case specific?
It's not case specific. It is like whenever I am doing a case wherein I myself am doing the post endodontic restorations, I would do a pre-endo buildup with a composite. Imagine I have a referred case wherein I am not doing the post endodontic restoration, a case which is referred only for the root canal treatment to me. In such a case, I don't do a composite pre-endo restoration. I would just place liquid dam, finish off the root canal treatment, and send off the patient. I'm not doing the post endodontic restoration there, right? In all cases where I'm doing the post endodontic restoration, I would prefer doing the pre-endo buildup with composites and go ahead with my RCT.
Okay. And
Okay.
sir, for proximal restorations, I've read somewhere about the snow plow technique where we use flowable composite
Global and
first,
packable.
packable. So in that technique, they are saying we don't light cure the flowable first.
We light cure everything last together.
Sir, do you advise that technique? Or I've also heard there is something called as modified snow plow technique where you first light cure the flowable and then do the packable.
Whenever you have light cured the flowable, it's never a snow plow.
Okay.
Fine.
So is snow plow
Whenever
technique?
you are applying composites in increments, it is an incremental technique. Whenever you are using flowable and packable together, it's a snowplow technique.
Okay. So do you advise light curing the flowable first, or without like snowplow technique? Which one do you
So
recommend?
it's like, see, snowplow technique is fabulous. Because of the weight of the packable, the flowable would move to each and every nook and corner. You will never have a porosity when you're doing this snowplow properly.
Okay.
Fine. And might as well imagine another situation wherein you have a microscope. When you have a microscope, when you're applying your composite in small layers, you would be able to see the bubbles and you would be able to remove them. So everything depends on how is all those things. Fine. So when you have a good microscope with you, when you're working through a microscope, it's not that necessary that you need to do snowplow every time.
Okay.
Fine.
And sir, one last question. For proximal restorations, in my clinic, we also have autometric system. Is it also as good as the sectional metric system, or which is better, or which is?
See, with the autometric system, you can use it for deep margin acquisition and elevation. When you are using it for a proximal contour buildup, you need a tooth separation so as to compensate for the space of the matrix band, which is not happening in an autometric system. So you need a sectional matrix with a sectional ring. If at all, you need to recreate the contact. The automatics is never going to recreate the contact.
Okay, thank you.
Fine. So you can go ahead, elevate your deep margin till the contact zone with your automatrix. And to rebuild the contact, you need a sectional matrix with a sectional ring. Okay.
Thank
you. Hi, sir. Thank you for patiently listening. I just want to ask, what's your opinion on H plus sealer?
See, I have only two sealers in my practice. One is the Edge Plus and the other one is the Ceraseal from Metabiomed. These are the only sealers I'm using. And I'm using them for the last 20 years. Ceraseal, of course, recently, maybe for the last 5 years, I would have been using.
Yeah.
The rest of them, and Edge Plus is something which I always prefer using. And I told you, I'm a big fan of warm vertical compaction. Something which works really well with warm vertical compaction would be the Edge Plus.
Yeah, my doubt is whenever I place H plus, patient complains of burning periapically even after
Of course,
LA.
see anything, any sealer, anything which goes periapically would cause a foreign body reaction. You would have a small Whelan flare reaction. If at
Even
all your
after
sealer
LA,
goes,
it's fine, right?
pardon?
Even after the LA, they sometimes complain that.
See, that is what I said. When any type goes periapically, there is the first thing that happens is a Whelan flare reaction.
Mm-hmm.
That's a foreign body reaction, right?
Okay.
Sir, then apical puffing is what when you use all ceramics?
Apical puffing is something which happens accidentally. Don't try for an apical puff. Sometimes it do happen. Fine. If it happens, fine. Okay. Nothing to go and do about that. But we never try to create a puff.
Okay, sir. But sir, sometimes it looks like packing of periapical
See, you are
area by
thinking that it is looking nice. But actually, what is happening when you have a puff, you have sent something periapically, your healing is never going. I mean, your healing is not the thing which is going to start now. The first thing that would be starting now would be a foreign body reaction from your body. Only then, only after that, your healing is going to start. So puffing is something which is unnecessary. Sometimes we are all human beings. We might land up in extruding a bit of sealer periapically. If so, fine, leave it. Otherwise, never struggle to create an apical puff.
Sir, in your lecture, you said you don't use orifice opener. Then, sir, how to enlarge the
I
orifice?
didn't say I never use orifice opener. I don't prefer using orifice opener. That is what I said.
Yes, but sir,
Orifice shapers, they have greater tapers. So I don't want to remove too much of dentin there. So I would prefer using a 6% tapered normal rotary file as my orifice shaper.
Okay, sir.
Okay.
Thank you, sir.
Thank you.
So how do you remove metapex from the tooth?
Sonic irrigation removes it very well.
Okay, sonic irrigation. Okay.
So just irrigate with distilled water into the metapex, agitate with the sonic irrigator, everything floats, flush it off.
Okay, sir. And any bonding agent you prefer, sir, in all your cases?
In a sense,
So which generation of bonding agent and which brand do you?
see, that's a, I mean, my preference would be always the gold standard bonding agents. I would always prefer using the 4th generation, which is the OptiBond FL, the 6th generation, which is the, the Clearfill SC bond and the Clearfill SC protect. These are the 3 bonding agents, and sometimes the 6th generation universal bond, that is the G2 from GC. These are the main bonding agents which I always prefer.
So what is the sequence of rotary filing, sir? BM biomechanical. I mean, they say K files are not used nowadays.
Who said K files are not used nowadays? You have to establish a glide path. If you can either use a K file for doing that, or you can use a rotary glide path file. Once after that, you can start with your rotary. Fine. So rotary instrumentation also, again, depending on the system, we have different techniques, different sequencing. And there is there are some universal rules, which if you follow any system you get, you can go ahead with that. So what is more important is before starting with the rotary, establish your glide path. Fine, it's not mandatory that you have to have a glide path rotary. You can do it with a 10K file also. So never start your rotary instrumentation without establishing a glide path. That is mandatory.
Okay, sir. As it creates ledge, K files are not preferred. They said that's what I asked, sir.
See, everything, if not managed properly, would lead to mishaps. If you are using a K file in the way it needs to be used, it will never create a ledge.
Okay, sir.
Fine,
So
I
what?
would always
Which
prefer
glide path
establishing a
files are?
glide path and then going ahead with a rotary. That is the actual protocol.
Okay. What are glide path files, sir? Commonly used.
They are 2% files, which it is like can be used with a endomotor.
Okay, sir. 2% files.
Yeah.
Yeah, okay, sir.
So when you do the coronal flaring, we can go with a 6% file without going with an orifice opener.
Yeah, that is what I am doing. I don't prefer orifice openers. I prefer a 6% file for straightening the orifice.
So very minute canals, can we enter with 6% directly?
A rotary, I mean, a glide path has there are glide path there are, coronal flaring files, which is going up to 10% taper also. So when they can accommodate a 20, when you can think of using a 10% taper, why not a 6% taper?
Yes, sir, because sometimes in the molar canals, the orifices are very small. So I have found it difficult
You
with the
will never be
6%.
able to use an orifice shaper before establishing the glide path.
No, of course, after the glide path,
So if
sir,
your
after the glide.
if your 10K file goes to the apex, then it is like coronally you would have at least enlarged to 40 or 45.
Oh, okay.
Fine. Then I mean
Okay,
it's like
okay.
a 25 has to
Yeah.
go, right? 25 for
Yeah,
the
yeah,
6% has
definitely,
to go, right?
definitely. Yes, sir. Okay. Thank you, sir.
Thank you.
Hello, sir.
Yeah.
So what are 5% files, sir?
What are 4% files?
The taper 5. The same, no,
So
sir?
what do you mean by taper of an instrument?
So for each 1 mm of the instrument, the taper,
Increases by?
Yeah, increases by
If
that
it's a
percent.
2%, it increases by 0.02 mm. If it's a 4% by 0.04 mm. If it's a 5% by 0.05 mm. If it's a 6%, 0.06 mm.
Okay, sir. No, sir. Actually, long back 5% were not in the market. Nowadays,
And
it's
that is
like
so. See, now we have 3%, 5%, everything we have.
Okay. Even 3% we have.
Yeah,
Okay,
we
sir.
have.
Okay, sir. Thank you, sir.
Okay.
Hello.
Yeah.
Good evening, sir.
Good evening.
Sorry, sir, I will not take much time as it is
You take
already.
time, no issues.
Sir, only just one query that is it advisable to use ultrasonic while putting sealer inside the canal or while putting calcium hydroxide into the canal and then use ultrasonics to just reach and to
I would not
flare
prefer
in?
that. My personal
Okay.
preference, I would say that I will never prefer using an ultrasonic while putting calcium hydroxide.
Okay.
Because
Just,
it is
just
like, no, it will not cause anything bad, but there is every chance you can push your calcium hydroxide periapically. Even if you push your calcium hydroxide periapically, nothing happens. But again, your healing time is delayed because the first thing your body would do is a foreign body reaction when you have calcium hydroxide in the periapex. Again, post-operative pain, all those things can happen.
okay.
Similarly, the sealer. You don't have any control over the apical movement of the sealer when you are using an ultrasonic.
Okay, sir.
Fine. So I would not prefer using an ultrasonic for either my sealer application or calcium hydroxide application.
Okay, sir, I have seen in the market something around rupees 5,000 ultrasonic. So, do you suggest to buy it? I have seen in some of the expo, it was the price of it was something around 4,500 to 5,000. So, do you suggest to use it, or should we invest more and buy the good one, good quality one for the proper irrigation and all?
Tell me once again, come again.
Sir, in the expos, I have seen one ultrasonic irrigation of worth the value of rupees 5,000 around.
That
It
is
was
used
totally.
to an activating device.
Yes, sir. Activating device. Yes, sir.
Yes.
Okay. So, do you suggest to invest in that, or should we invest more and we should buy the better option?
See, you can get an ultrasonic tip at 500 rupees also.
Okay.
That is, if you go to dental card, you will get the ultrasonic irrigating tip from many Chinese companies, which can fit on your scaler.
Yes, I till now I'm using that only.
That works fabulously.
Okay.
Now, let's come to the disadvantages of that. It
Okay.
will not be able to activate the irrigant into the curvatures of the canal. Fine, because your metal tip will not be able to go into the curvatures of the canal. Fine. Ultrasonic will get dampened the moment it touches the canal walls.
Yes.
Fine. So again, the disadvantage is you will not be able to activate the irrigant without touching the canal wall.
Okay.
So again, the complete ultrasonic, efficacy of your tip is never going to come into action, right? One thing, you will not be able to go past the curvature. Two things.
Yes.
What if you are using a flexible plastic tip? You will be able to take, this can go into the curvatures, right? So earlier we used to have the ultrasonic polycarbonate tips. Now we don't have that in the market. So what we do is we use sonic irrigation.
Okay.
So sonic, again, when we see the literature, it is, though sonic irrigation is not that good as ultrasonic irrigation, activation is not as good as ultrasonic activation. Still here, it can go into the curvatures. All those things are excellent with sonics. So end of the day, the result is the same.
Okay.
Fine. So, I would prefer using a sonic. The reason being, it is like I can go into the curvatures, the tip being plastic. If it breaks, also it floats inside the canal. Fine. I don't have to attach it to a scaler. I can attach it to my aeroter point and work. So my favorite unit, see, I'm not a marketing person for any companies. So my personal preference, since you asked, I'm saying I would always use the patch.
Okay, sir.
Fine.
Thank you so
Good evening,
much.
sir.
Pardon?
Good evening, sir.
Good
So,
evening.
do you believe in WVC condensation or the hot vertical compaction condensation? Which you believe has more success rate in your practice? What you have seen?
Warm vertical compaction is WVC.
Yes, WVC, exactly. That's what I meant. That's right. How do you feel like it has got, it can cover the lateral canals and all these things?
The best method of compaction is warm vertical compaction anytime. No doubt about that.
Okay, okay.
But the only issue is, see, we know every sealer contracts on setting.
That's fine. Okay, okay.
So imagine you're using a resin-based sealer and warm vertical compaction. End of the compaction, after the sealer sets, there is always micro gaps going to come.
Okay, okay.
So that was the drawback of the technique. Now it is like, imagine you have a bioceramic sealer, which is the only sealer which is expanding on setting.
Okay, okay.
So now you don't have to use a warm vertical compaction. You just use a single cone and bioceramic. The sealer expands on setting. You are getting the same result, right?
But I just want to know, how do you fill the lateral canals other than using the warm vertical?
Nobody will fill lateral canals.
You cannot fill in cleaning by irrigation, whatever. Sir.
Nobody is going to purposely fill a lateral canal. If it is happening, it is by fluke. Or rather, I can say that when you have cleaned nicely, your sealer will flow into that.
Okay, okay.
Fine.
Thank you. Thank you.
Sir, what is the waiting period between two calcium hydroxide dressings?
Always
And
night.
and what is
14 days.
the 3 days?
14, 14.
14 days. And sir, till how many months we have to wait to see the lesion is healing or no? Like to come to the
So,
conclusion whether
for you
extraction.
to notice an appreciable change in the IOPA, minimum you need 4 weeks.
Okay, sir. Thank you.
So it is like we have to recall the patient every month, repeat the IOPA. At least a month you have to wait to see any appreciable healing on the radiograph.
Sure, sir. Thank you.
Thank you.
हेलो
Yeah.
हेलो गुड इवनिंग सर
Good evening.
हेलो सर मुझे एक डाउट था ये 4% टेपर और 6% टेपर फाइल्स अलग कौन से केसेस में यूज करना चाहिए सर
See,
फोर
imagine you have a thin root, for example, the mesial roots of mandibular molars or the buccal roots of maxillary molars, they are very thin.
हेलो
So imagine the buccal roots of maxillary molars and mesial roots of mandibular molars.
यस यस सर
Imagine they are very thin roots. So usually if you see the Indian population, we mostly have thin mesial roots on mandibular molars and thin buccal roots on maxillary molars. Unlike the European, or the American population.
यस सर
So when you have a thin root, if at all you are going to a 6% enlargement, there is no dentin left at the end of your preparation.
यस
At
सर
the same time, on the preoperative X-ray, if you see a thick, broad root, it doesn't matter, you go to 6% enlargement also.
ओके
Okay.
So sir in mesial and distal maxillary distal root we need to use 4% taper
See, you don't have to use a 6% in most of your cases if your irrigation is very good.
okay means
You can always stop in 4% case. 4% when your irrigation is very good.
okay sir thank you
If at all you don't have any method of activating your irrigant, always prefer using a 6% because on its own hypochlorite can establish its best efficacy when you have created a 6% taper. So if at all you are not using any irrigant activation techniques in your clinic, go for the 6% taper. You get good cleanliness.
okay
In case you have an irrigant activation device, it doesn't matter if you stop at 4 also.
okay sir fine
Okay.
Okay sir thank you
Thank you.
sir can
Good
you share
evening.
your contact number
Of course, I had given the contact number. It was there on the slide. My last slide had given all the contact numbers. So let me see. 1 sec. You got it?
it's not clear yes yes sir got it
Thank you.
yes
Good evening,
thank
sir.
Good
Sir,
evening.
just a witty question. Sir, I saw in a reel attaching the master cone in the contra-ankle micro motor handpiece and doing irrigation with it. Sir, does it work?
See, we always say that something is better than nothing, right?
Yes, sir. Right.
So similarly, it works.
Yes,
It
sir.
works.
Because...
I'm not saying it will not work. It works.
Thank you, sir.
Sir, hello, sir.
Yeah, I'm hearing you.
Does this internal bleaching work on tooth that has been root canal treated like 10 years back?
I showed you a case, no? It was like wherein it was totally black in color. It was root canal treated some 20 years back.
Okay.
It works everywhere. It works.
Okay. Thank you. Sir, but I have one question. Sir, during preparation, all this crown and all, what should the bird types, steel birds or carbide birds, what is good for endo preparation?
See,
Hello?
If at all you are going for bondability,
Yes.
the
Bondability.
the
Direct,
bond
indirect.
strength, the bond strength is always better if you are done your preparation with a diamond bar
Okay.
than your tungsten carbide.
Sir, steel bar is what for your
Tungsten
in
carbide.
steel is what?
Tungsten carbide, TC.
Okay. Two types
It's
bars
not a steel bar,
are
it's a
available
tungsten
only.
carbide bar.
Okay, two types bar are there, na? Ki what
The
one
TC,
is
the tungsten carbide, and the diamond bar.
diamond bar. Both are good.
Both are good. Bone strength is always, that is my thesis topic. That is why I can tell that with authority. It's like we have proved that bone strength is always better when you're using a diamond bar.
Okay, sir. Thank you.
Hello, sir. Good evening.
Good evening, Jack, again.
I am PG second year student.
Yeah.
Sir, I have one doubt that like you say ki,
Pardon?
so what the breaching of the pulp chamber you say na breaching like with the help of Cephane we once we get the canal with the help of round bar then we use Cephane and we go for searching the for next canal. So what do you mean breaching of the pulp chamber is a breaching of
Breaching. Breach means a discontinuity.
breaching? Okay.
Breach. A breach on the roof. That is like, imagine you're doing a deep caries excavation. Would you create an exposure? Pulp exposure?
Yes.
Yeah. What is that actually? A breach on the roof of the pulp chamber, right? So that is your first landmark when you're doing a root canal treatment. Once you create your breach, take your burr into through the breach, then in outward strokes, you remove all the roof.
Okay. Okay, sir.
Fine. So now it's around 11:30. So we usually plan a 2-hour session. So it was nice acquaintance with you all for 2.5 hours we were discussing. And see, now it is like I told you, the intention of this program is to introduce the newer concepts to you. If you're interested in really learning about them, you can join our programs. I'll go to the slide share. So you can click a photograph or you can take a screenshot of the slide. All the numbers are there. So you can contact us. And then together we would improve the quality of dentistry we would give to our patients. So with this, can I stop the session today?
Just one last question, sir.
Sure, go ahead.
Just want to know which endomotor is best for minimal file breakage.
There is nothing like that, man. It's like, see, I told you, no, something which we all have to understand is we are the most important component. When we
That's
started
right.
with our journey on endodontics, when I was doing my PG, we were never having the electric endomotors. We were using the analog ones, the geared handpieces, the antho gears. Fine. So it is like even with that we have managed years together without a file breakage. Fine. So it all depends on how we are using it. Every technique has a protocol. If you're strictly following the protocol, you will be able to minimize your file breakages. Of course, there is a bit of factors associated with your handpiece also, like the torque jump and things like that. So stick to something from a reputed company. It all works well.
Can you suggest someone?
I would say Xmart from Dentsply. If you're going for the Chinese, you can go for the woodpeckers.
Okay.
Sir, one more question, please. Last.
Fine. Or if you're really interested, it's like we have our endomotor, you can buy that. It's again really good, but it's not good from my side to market my own products. So if you're really good, I can send you that also. It would be cheaper and it would be working really well also.
Okay. So
Thank you.
Thank you.
Sir, I have questions.
Pardon, tell me.
सर जब सर मैं मतलब समटाइम मैं आई थिंक लाइक कि व्हाट इज द एक्चुअली व्हाट नीड द कैरिस डिटेक्टर डाइज बिकॉज all the area are affected we should remove ना then what is the use of this carrier detector dye क्योंकि हमको तो पता है ना affected infected dentin जब we remove
I
all
didn't
the
say that you need a caries detector dye for a root canal treatment axis of knee.
yes no need na sir no need
No, that is what
carrier
you know.
detector because all area which are affected we should remove.
I was
Then
using a caries detector dye for those cases wherein I was avoiding a root canal treatment.
yes
So
sir
whenever
for
I want to avoid a root canal treatment, I might use a caries detector dye. When I'm doing a root canal treatment, I'll not use it.
Yes. Actually, I think that. And sir, when we use for restoration, indirect restoration, then carriage detector dye, how to use, मतलब ये affected infected dentin, dark color, light color, मतलब almost same. What is the criteria? मतलब I don't think कि this is very much good for, मतलब I don't think कि क्या
Depends
करना
on which
चाहिए?
caries detector dye you are using.
What you suggest, sir?
The best or the gold standard caries detector dye is only curare.
Okay, sir. Okay.
Fine.
Nice. Sir, what is the criteria? मतलब dark pink, light pink, like that, no?
Nothing. Whatever stains red is your outer caries dentin, you have to remove that. Whatever remains, stains pink is your inner caries dentin, you can keep that.
Okay, red and pink are differentiated.
Yeah.
Okay, sir. Thank you.
Thank you.
Hi, sir. Last question. I just wanted to know earlier there was a technique in a huge lesion. We used to take the file, 2% file, 10 number periapically and induce the fresh bleeding and then wait for 7 days and to see the lesion change. So, do we practice that right now also?
You push it periapically, induce a bleeding into the canal and wait for 7 days for what?
No, sir, like to induce there is a lesion, huge periapical lesion. So earlier they used to do 2% file. They
No,
take
ma'am.
it periapically.
Ma'am, let me speak now. It's like, first of all, when we are talking about a technique, you have to see that whether that is evidence-based. Fine. Most of these things, it is like people do n number of things. But what makes the difference is, or what we have to follow is something which is evidence-based. There is no technique as to you going periapically, irritating, inducing bleeding. Of course, we do that in revascularization. And that happens only in wide open apices or wide open canals. Fine. So we never had a technique of going periapically, inducing bleeding and waiting for 7 days. That is all individual variations of the actual technique. So whenever we are thinking of a technique, you open your Google, just check for the availability of literatures on that. If it's evidence based, go ahead, do it.
Okay, sir. Thank you.
Thank you.
सर जी मेरा एक क्वेश्चन है
हेलो या टेल मी
तो सर ब्रोकन फाइल को रिमूव करने के लिए केनाल से कौन से फाइल रिट्रीवल सिस्टम बेस्ट यूज करते हैं?
No, that is what I said. See, I always say what is most important is your skill. When you're skilled, even it's like anything works for you. And to me, I would say that I always use ultrasonic tips and the loops to retrieve.
Sir, tell me one thing. Now, bypass technique is more effective as compared to file retrieval system, or file retrieval system device is more effective than the bypass technique?
See, I told you, when you can see, you can retrieve.
Yes, sir.
If you don't see the instrument, it makes more sense to bypass it.
Yes.
Again, in cases like imagine a very long file. If I have a very long file with a big diameter, it's too difficult to bypass it all the way down. I would prefer exposing the neck of it and retrieving it out. Fine.
What kind of, sir, this is my last question. Now in MB2 canal, after accessing MB2 canal, how to use irrigation protocol by you, it is done.
Irrigation protocol is always the same. I use my choice of irrigation would be the continuous chylation irrigation, wherein I would combine a chelating agent to my hypochlorite.
Yes.
Fine, and I would always use a sonic activation, or else something which recently I've started is the CRCC, which is a device which can induce continuous irrigation and suction. So either I would be using the continuous chylation irrigation or the CRCC. Fine, and it depends. The irrigation protocols are the same. Whichever canal, whatever canal it is, the protocol remains the same. It remains the same for MB1 and MB2.
MB2 कैनाल में 4%, 2%, 6% जो मेरा मास्टर कोन फाइनली जो मेरा फिनिशिंग फाइल है वो जा रहा है, तो वो लास्ट जनरली मैं जाता हूँ 4% पे, तो 4% पे ऑब्जर्वेशन मैं देखता हूँ कि हुआ है
that is what I said. See, it's like see these fine aspects. I would prefer you to join a program so that these things can be very well discussed in detail. Fine. Now at this hour, it's like I don't think I should be sitting for more time to discuss about that.
Thanks, sir.
Okay.
Sir, when we keep the breakage file in the canal, in which cases we can keep those that will not pain in future the patient?
In no cases we can give a guarantee that it will not give any pain. But it is like if at all pre-operatively you never had a lesion, then there are chances of high for you. The prognosis is better. Or in such cases wherein it is like your file broke after your cleaning and shaping. Or towards the end of your cleaning protocol, if at all your file broke, again, you would have a better prognosis.
Okay, sir.
So,
sir,
there is
any
another
medication
question over here
prepared?
in the chat, which it is like, it is a nice question. I feel somebody has asked me, but these unsupported walls of the tooth are healthy tooth. Why it is important to remove it? Fine. See, this is what happens to us. It is like, see, a tooth, a tooth is like, an enamel behaves like enamel is a brittle material which behaves like glass, something like that. So when the thickness of enamel is lesser and in repeated chewing cycles, cracks would develop on the unsupported enamel. These cracks would progress together. Many such cracks would coalesce and a portion of the tooth would fracture off. That is why we always say we need to break off the unsupported enamel. Fine. So, what I understand from all these questions is our understanding of the subject dentistry is very, very, very less. Yeah.
This is my last question now.
Yeah, tell me.
बायोमिमेटिक डेंटिस्ट्री का सिंपल सा मतलब क्या होता है? I didn't get in better way understanding about biomimetic.
Biomimetic dentistry is about re-engineering a tooth. Normal conventional dentistry में क्या होता है? You fill it's like you dig a hole and fill it. But it's been proven that a decay tooth is always stronger than a filled tooth. So simply removing a decay by drilling weakens the tooth. In biomimetics, we replace the dentin, we replace the dentin-enamel junction, and we replace the enamel, and we re-engineer the tooth just like how it was before.
Got it.
Thank you. And with this, now I'm
Sir,
really
any
just
dissolving agent we can
11:41.
use?
Now it is like I would put an end to this. Otherwise, it goes on till tomorrow morning. Because I'm really tired. It's very late. So we were supposed to have this session till 11 o'clock. It's already 11:45, and I would stop it now. And thank you
Sir,
all for the pleasant
Thank you, sir.
hearing.
Thank you, sir.
Thank you. Thank you.
sir, one last question.
Thank you, sir.
ઓલા જે જો લેટર અપલોડ થયા છે તારું આવ્યું છે કે નહીં તો પેલા થતું જ નતું પછી બોલે કે તારું આવે સવારે કેજે